All right, everybody. Welcome to Compliance After Dark with the Chuckleheads. So, this is another live episode of Coffee, Compliance, and Chuckleheads with Jordan Johnson, Eric Rubenstein, and yours truly. Uh, Thought that I would just get into the spirit of fall, throw on a little flannel, a little cowboy hat, giddy up because it's going to be a wild ride. So, guys, welcome. Hope y'all are doing well. Uh, Jordan, you're looking good, my friend.
Hey, always energetic, ready to go. Got the hat. I feel like Eric, we left him out, man. I got the crazy, we got to get Eric the hat.
Yeah, we got to get Eric a hat.
I'm good. I'm good.
Um,
I'm good. I mean, between that push broom over your lip and the New York City taxi cab hat you got going on, the only thing you're missing is a paper route.
And we're off and running. All right. So tonight, that's right. So, tonight, I think we have an outstanding episode for you. And I want to welcome, because our show is growing every single day and we're getting new viewers every single day. And I want to welcome all our new fans. Welcome. We hope you enjoy the circus where the show is always the same, but the clowns are what changes. So we got a lot going on, right? And one of the first things that I wanted to talk about, because this is really big news, and I'm going to go ahead and take this off because I know it becomes a distraction, that sexy hat, and I'm going to make myself more at home now. All right, here we go. So here's the thing. And yes, Eric, it is a Boston Red Sox hat. It's a Boston Braves hat. Okay, so I want to talk about a couple of things that are going on right now. Number one, obviously, we all know that today the Biden-Harris administration released their vaccine mandates for healthcare providers in the private sector for workers. Really important that, the interim final rule is now requiring COVID-19 vaccinations for all healthcare workers within Medicare and Medicaid certified facilities. Guys, this is huge, right? Huge. And here's what it says, okay? Eligible staff have to receive their first dose of a 2-dose COVID-19 vaccine or a 1-dose vaccine, which obviously is the Johnson & Johnson, by December 5 of 2021. And they all must be fully vaccinated by January 4 of 2022. Now, the regulation itself does provide for exemptions based on one, recognized medical conditions, or two, religious beliefs, observances, or practices. But the really interesting thing that when you read this this new mandate released by the administration is that there's no testing exception in the healthcare setting. So in other settings, you have the option of either getting vaccinated or weekly testing. In the healthcare setting, there's no exception. And I believe that there's going to be some significant challenges that come out of this thing.
We're seeing that in places like New York City, right, where the fire department, the police department, the schools, New York City Department of Corrections, they're all doing that now. You got the fire departments had a sick out. The teachers union was able to get a stay on that until December. They're all, there's going to be significant challenge. My fear is that when you create the mandate, and this is not about whether the mandate should be there, but anytime you create a policy, you're also creating fraud. And we're already seeing that now with the proliferation of the combination of the fake cards and then real cards with actual information for people to buy, with an actual lot number and the dates of a shot in the arm that never took place. So are we going to be seeing that? What's the ability? The ability to control these cards is zero. There's just no way to control them. It's a pack of blank cards.
Right.
with a good scanner, I can make one.
Yep. And here's the thing, folks, please keep in mind, this is an interim final rule. So that means we have 60 days after the date of this publication for people to be able to comment back into the Federal Register. So please keep that in mind, because this is an interim final rule at this point. So be aware of this stuff. But yeah, I thought it was a very, very aggressive stance to take, considering the number of healthcare workers that are saying, I'm willing to walk away from a 10-year, 15, 20, 30-year career out of principle. And I want to be crystal clear with everybody that's watching our show. None of us here are anti-vaxxers. None of us. I am fully vaccinated. I just personally believe in people's right to choose. Period. That's it. I believe in people's right to choose. That's the end of the story. I don't need to get into a whole diatribe about this. I don't need to get into a whole political argument, because we have enough politicizing of this issue, which shouldn't be going on right now with the yahoos up in Washington, D.C. We need to focus on the facts, and we need to focus on the fact that without these essential healthcare workers, these firefighters, these police officers, these nurses, physicians, our health system that's already in big, big trouble is going to be even worse off.
Did they say anything about tying it to, and I haven't read it, but tying it to reimbursement at all? Like, that was just a question I was thinking.
Yeah. So there was some initial, and I got to be honest, I have not read the entire interim rule at this point, but there was some initial conversation about the fact that they were going to consider suspending payments to any Medicare certified entities that were out of compliance.
Yep.
Well, so the first question is the compliance going to be a self-certification? And then, because how do you actually police the thousands of hospitals, the thousands of SNFs, the thousands of rehabilitation centers, acute care, all of that, rural hospitals? Rural hospitals would suffer tremendously if you have a rural hospital where a large percentage of people are choosing not to get vaccinated, what have you. I think there's actually been a few stories in the news that I've read where that's been an issue in some of the rural communities where there's limited staff to begin with. Some of these critical access hospitals and rural hospitals. What do you do? So is it a self-certifying compliance? And if you're out of compliance, are you going to get, is there a daily fine? Is it going to be similar to the Office of Civil Rights with HIPAA violations, or Office of National Coordinator with price transparency? Is there
a $100 fine?
But you do that every day. A rural community hospital who's got the thinnest of thin margins because it's a 70-bed hospital. What happens there? I mean, are you putting a facility in a position where they have to provide a false certification? The fact that they're not even putting a percentage in, so that they always talk about the general public has to have the herd immunity, 70 or 80%. And just as an offshoot, what I'm still perplexed at is, why is it that when there's a percentage of people in the population who've had COVID, and there's a lot of tangential or colloquial or even fact-based evidence that having been infected with COVID provides you with immunity that is similar to or better than the vaccine, why is it that those people are not included in the percentage of people? So when they say we have a 55% vaccination rate, or a 60%, whatever that number is, it doesn't matter what the number is, why is it that you're not including those who have had COVID, which I think is in a large part a lot of what the union arguments are making, and a lot of these hospitals where the staff is saying, you're making me get a vaccination, I've had COVID, why don't I get an exemption for that? So if you're putting this 100%, I think it's going to be difficult. There's going to be a lot of challenges, but I can also see all of the people who want to keep and need to keep their job, making a card up on their computer at home.
I think you're right, and I think this is going to be a big problem. Now, there was a second thing that was also released by the U.S. Department of Labor, right? Under the Occupational Safety and Health Administration, so we're talking about OSHA. they released their emergency temporary standard, what's referred to as an ETS. And an ETS, for those who are not familiar with it, this is a type of regulation that takes immediate effect, right? There's no waiting period, there's no grace period. This is an emergency temporary standard. And it's good for, during the comment period, about 30 days, if I'm not mistaken. But I'll share this with you. What's going on here is that they indicated or identified what they refer to as quote unquote grave dangers to workers. And now they are requiring all businesses with 100 or more employees to mandate a COVID-19 vaccination for their workers, or have workers show a weekly negative test and continue to wear masks. So you're getting that option outside of healthcare, right? You can weekly test, you can wear a mask. But if you're going to require the mandates, all employees have to be fully vaccinated no later than January 4th of 2022. Now, comments on the ETS are due within 30 days of today's date. So, folks, if you have an issue with these, respond. Let your voice be heard. Okay.
Well, that's my other thought is, say you go down the road of having to have a test every week, right? Or show that every week. Accumulation of that cost is astronomical. Like,
Right.
does CMS just continue to write and pay for that? I mean, who's paying for that?
No, I think there's isn't there a car? So if you've got a mandated employer-based testing, I think that's a car. So HRSA is not going to pay for that.
Nope.
Commercial insurance may not pay for that. That's going to be either an employer having to pay for that, or it's going to be a cash price, that the employee will have to take the burden. No employee is going to pay for this, right? So if you choose to not get the vaccine, you choose to just go into the weekly testing. I know I have friends in New Jersey who are police officers, and they're in police departments where they're not mandating the vaccine has not been mandated for all police officers in New Jersey. I have a very good friend who's not getting the vaccination, and he's twice a week testing, and he shows up to work. And when he shows up, he, clocks in, and then he goes to a place, gets a test, and then goes about his day. But twice a week, he'll have to get tested, and the police department is covering the cost of that.
Yeah. Now, the other thing that happened today, actually yesterday, was the release of the CMS calendar year 2022 Medicare physician fee schedule, right? So I know, Jordan, you got hammered with a lot of stuff with the inpatient rule, with OPPS, and some of the other stuff. Here's what I will tell you. The actual document itself, the Federal Register, is approximately 2,400 pages. It
Correct.
is a lot to read. I can tell you a couple of high-level things, and then, Jordan, I want to turn it over to you. The conversion for next year is going to be $33.59. So that, again, is another decrease from what we saw in 2021 of $1.30. Okay, that is a $1.30 decrease. Next year's rate accounts for statutory changes, relative value units, and the expiration of the 3.75% temporary calendar year 2021 payment increase that Congress approved through the pandemic-related legislation. There's two quick points, and I'll zip my lips for a few minutes. The calendar year 2022 conversion factor also reflects a statutory update of 0% and an adjustment necessary to account for changes in RVUs and expenses that would result from the finalized policies from what's documented in the final rule. And second, there are other finalized policies included in the elimination of geographic barriers when it comes to using telehealth for behavioral health care. And again, the final rule enables patients to access telehealth services in their homes versus a qualifying healthcare site for diagnosis, evaluation, and treatment of mental health disorders. I think that's one of the biggest things to come out of this. This is huge. Extending telehealth services to the mental health community. I know, Eric, as a former law enforcement officer, you look at this and you go, great, more opportunities for fraud, waste, and abuse. And I agree with you. There's going to be people taking advantage of this thing, no doubt. But this is a community, and anybody who knows me knows that I am a huge advocate in the mental health arena. My brother, God rest his soul, committed suicide in 2013. Had we had access back then, or I'm sorry, in 2003, I said 2013, I apologize. In 2003, had he had better access to mental health care, maybe he'd still be with us here today. I don't know. But all I know is I'm grateful for the fact that Congress is finally coming into the 21st century and making it possible for individuals with mental health disorders and mental health disease to get the necessary access to care that they need. And this goes to your point, Eric, about, rural health and the shortages that they have there and the budget constraints. So this could help to alleviate some of these problems.
Yeah, no, that's true. I mean, I think you look at it from this 360-degree view that the CMS has unfortunately been always, because of the fact that these are rules and regulations that have to be promulgated by them, they've always been a little bit behind the curve when it came to telemental health, and the commercial payers have always been a lot more on the ball with that and getting things done a little bit faster. So this is it's a pretty important piece, but the thing that always strikes is that whenever you've created an expansion of something, you've created an opportunity for something else. And that really is always going to be the issue. So CMS is reporting, and I think the Congressional Budget Office or Office of Management Budget, one of them, is reporting that by 2026, Medicare will start to become insolvent, and Social Security by 2033. They're talking about, reductions in payments. And so part of the problem then becomes that when you've done things like looking to expand services, right? That's one of the big things right now that's being talked about with respect to vision and hearing and dental. As you expand a program, there's a social detriment to health that you've now taken away, which is a very important piece. But there's also the greater opportunity. I mean, we're seeing that with all of the telefrauds that are out there, not the telehealth, because we don't want to call it that, but with the telefrauds, we're seeing that. And I think that the benefit obviously is, look, COVID had some very, very severe mental health consequences on people who took it as serious as they felt they needed to take it, and really changed the way that they interacted with humanity. And so there are going to be some long-term mental health issues that come about as a result of that. And so it's a great step in the right direction. You have to be able, it's not just the availability of care, but it's the access to the availability of care. And when you look at access and availability, those are social detriments to healthcare. If you don't have one or the other, you're creating a social detriment to healthcare. So, and we're seeing it collaterally, all of the effects of COVID and the inordinate amount of money that's been dumped into dealing with COVID, and now the enforcement of it. And you made a comment about it today on LinkedIn, and Jordan, I know you were busy in something today, so you didn't get a chance to see it, but Sean made a great point about, like, at what point do we stop seeing these people who have no business being in the healthcare industry causing $100 million in fraudulent claims to go out? Like, at what point does it stop? And I think it then goes back to Jordan's piece of this whole puzzle, which is the data, and being able to appropriately cull data to stop these things from happening. So while I really am excited to know that the behavioral health piece is going to be part of it, I just think that when doing that, what are the stopgap measures that are going to be put in place to ensure that it's not $100 million in fraud, and now it's not 2026, it's 2025.
Yeah, I agree with you. And here's the thing, and I mean this sincerely, and I hope who's ever listening to this, take it however you want. Our justice system is completely broken. When you punish individuals for when you punish individuals in a way that doesn't send a clear message that we're not going to tolerate this behavior, it opens the floodgates and it opens the doors for more and more just scuzzy individuals coming into our industry. Eric, you and I have been working on a number of cases, right? You and I. And these are all tied to Office of Inspector General, that are tied to these DME frauds that are taking place, these telefrauds that are taking place. These are individuals who are gaining access via public use files to NPI numbers and to providers' PTANs. And then they're going out and they're getting these enumerators, right? So they're getting their own PTAN numbers. And what they're doing before they're even billing the very first service is they're doing multiple changes of ownerships, multiple chows. So they're creating all of these different layers to be able to insulate themselves from being caught. And they're creating a level of complexity that's making it nearly impossible for the good men and women at the OIG and at the FBI and these other investigatory agencies to be able to keep up with it, to be able to detect the kind of schemes and scams that are taking place, to be able to nail these slime buckets.
Yeah, it's so much work. And that's the thing where, I have conversations with people on a pretty regular basis and pretty vocal about it on places like LinkedIn, where people just don't understand, why is it that it took you 3 years for this case to come to fruition, or why did it take 2 years? And it's a matter of, when you've got someone involved with a change of ownership and it's gone through 6 changes of ownership, or 5, I'm entirely making up numbers, you have to track all of that down. The U.S. Attorney's Office does not charge an individual that they do not believe they have a success, that at the end of the day will be a successful prosecution. And when the U.S. Attorney's Office is looking to charge an individual, they're charging the individual because they're ready to go. This isn't, we're going to roll the dice and see how this works out. This is, let's get this all done. And it takes a long time to do it. Massaging data, Jordan and I are working on some projects with data analytics. And sometimes just to get the data the way that it needs to be for any project, in a manner in which you can pull out the pieces of the puzzle that are important, could take weeks. It could take weeks. It could take months. I mean, the stuff that you and I are working on, it takes a very long time to get the information. We're on the side of the OIG, right? Our clients are victims in this, and it still takes 2 weeks to get the OIG back the things they need, and then all of that follow-up and all those pieces of the puzzle. The thing is always going to be that people who aren't working cases as an investigator will never really appreciate or understand the amount of effort that goes in to get to the point of charging someone, because nobody just sits in a room and just dings an insurance program from their home laptop without any protections for their identity or any of that, or any even purview. The most difficult cases that could be work, or kickback cases in Florida. In Florida, even the healthcare fraud cases in South Florida, when the strike force started, those were DME companies operating at addresses that were dirt lots. It didn't exist. When the strike force started in Brooklyn, those were actual clinics seeing actual people, in which kickbacks were paid for the use of their Medicare numbers behind closed doors. You know how difficult it is to work on a case of that magnitude, and then to go through the data and then try to find those needles in the haystack. I mean, Jordan does that every day just with pricing, like trying to find, like, where is the pricing? Like, think about when you've got stuff in front of you that you're dealing with and you already know where to look, and try to think about how do you do that on the things that you don't know that you're trying to figure out. So these are all things that, the world's problems are, every day it's another version of that.
Yeah, well said. And, I agree with you. Like I said, I did not work within the OIG, but I've had the privilege to work with the great men and women of the OIG for almost 2 decades on a number of different cases. and on a variety of different studies and opinions and things of that nature. And I will tell you, just on the ones that you and I over the last month, Eric, what we've been working on, those things are tiresome, man. I mean, the number of charts that you have to go through, the herding of cats, which is really what it is when you're trying to get providers to respond to these things, especially when they're not the suspect of the investigation. They're like, well, yeah, I'll get to it. No, you don't understand. If you don't get to it now, OIG is going to issue a subpoena, and you getting issued a subpoena is not a good look. So wake up and get after this. But you're right. I mean, these cases, because of the levels of complexity, the layers of things that go on in these cases, they take a long time. Look, I want to be clear. We review on a weekly basis dozens of cases, dozens. If you asked me what cases I worked on last week, unless it was something profound, I will tell you, I don't know. I probably had 3 or 4 that were $250,000. I probably had 2 or 3 that were $1 million. I probably had a couple that were $10,000. I don't know. But in a year, we probably collaborate on probably 100 cases a year. I mean, this is how bad the system is. This is how bad the actors are out there. And we need serious people to create serious solutions.
Well, that's
where we're at.
Yeah, and kind of the flip to that is, not even the flip, but the other side is, that's why we've been so hard on, Judith Faulkner and her bunch up there at Epic and Cerner, and we've got no standardization. If you read the final rule yesterday or listened, the price transparency is absolutely moving forward. The penalties, they're not backing off. They're not delaying it. But it went back, and they had to highlight. They told people to publish 5 columns. And when you read that 40-page section that's in there, 60-page section about the people that put CAPTCHA passwords where you couldn't get to it, password protected, like, we've got to get to a level in the medical record to what Eric's talking about is, and this other stuff, compliance in publishing data. Then there's got to be some level of structure. I mean, there's 100 plus EMR EHRs out there. All of them, can submit claims. That's great. But when we're running data reports, they all look different. They all do things different. We've got to the only way we're going to accomplish anything, to Eric's point, is through data. Now, to get there, it's going to take standardization. It's going to take and compliance. And how do you enforce that? Whose job is it? I think we're definitely moving in the right direction. We have a long way to go, but it's a daunting task, like you guys are saying, for the time and resources that one case could consume.
Oh, absolutely. Go ahead.
The question
I'm sorry.
Why isn't there some sort of a standard in the EMR world? So there's standards in submitting claims. Right. If you're a pharmacy, you have to submit claims pursuant to the NCPDP's D.0 system. Yep. If you're submitting a claim to Medicare, you've got an EDI interface that's got to be consistent across payers. It's you would think in an EMR system, they all basically do the same thing at the end of the day. Yep. The consistency. So the problem becomes when some of the projects that I'm working on with Jordan, we're getting an extraction of data, and it's coming from 2 or 3 different systems. Right. And it's a matter of getting that data. It's all got to be structured the same to be able to analyze it. Column A has got to be column A through 3 different data sets. It's got to be the same. Otherwise, it's, you're working twice as hard. I mean, it could be the fact that it's structured, but it's not structured the same. You would think, so CMS comes out, originally it was meaningful use. Then it was changed to interoperability, and the Office of the National Coordinator comes in. Like it's almost like they dance around the importance of continuity of data but they don't really get to the heart of it. So there's, price transparency, and this has to be provided. And the ONC comes out with interoperability, which really, it's only interoperable if the three of us are all doctors in practices that are all part of the same health system. But
that's right.
If we're all down the street from each other and we're using different systems and there's no interoperability and there's no, that just doesn't exist. So,
well, if you read those in the final rule and all this stuff that's coming out, they always make mention, and you've seen this pickup of the API. This API is going to become important for all this. So used to, it was like, if you can run me a report, but these API connections by software, and it's going to get forced. I mean, by pharmacy, commercial payers, all this is going to get forced. That's when the level of access to data increases exponentially. Now, the level of access does, but the level of structure and consistency doesn't. And so I think that's when you'll see your mid-cap vendors and things like that really go in to try to do what you're saying, Eric, is there's got to be a level of structure. Because right now, you export anything, it's got to be ingested, worked, massaged, cleaned, you name it. And that takes so much time and resources.
Let me stop you for 1 second.
Right? No, go ahead.
No. Because I don't think people realize what goes into data analysis. Okay. I had my first opportunity to watch you live on a webinar yesterday. Buddy, you crushed it. You crushed it. And that's the truth, man. I've been so privileged over 2+ decades to work with who I believe is one of the greatest statisticians, one of the pioneers in advanced mathematics and predictive analytic modeling and augmented intelligence, and Frank Cohen. The guy's just unbelievable. And the number of cases and the type of cases that this guy has worked over his incredible 35, 40-year career. I mean, this guy taught me statistics, and I don't have a PhD, right? I don't have these crazy degrees that, some others have out there, but I will tell you, my level of appreciation for what goes into data analysis and what goes into having to be able to segregate information, to be able to flesh out what's garbage versus what's usable data. And let me tell you something, that is not an easy feat. And that is something that is not learned overnight. That's a skill that's honed over a person's professional career. And by having exposure to people, that we are so fortunate and blessed to be able to work with. And that's one of the other reasons, to Eric's point, why these cases take so long to bring to fruition. I mean, we have a case right now that we're working on, we just got it, 2 days ago, and it's like 386,000 lines of dumpster data, right? I mean, most people were fortunate, right? Because they go out and they subscribe to an analytical program and they run their utilization reports and they dump their data into that, but they don't understand where the formulas are coming from or what the formulas actually tell them. And they get this information spit out to them that says you're an outlier or you have an aberrance or you are underbilling for your services. And they look at it and they go, okay, how did you determine that?
Exactly. And I think that's the problem with the big mid-cap or the huge vendors is they come out with this software and you're taking them at face value that the graph is correct, the numbers are correct. Is it? Because it very well may not be. Like, how was the data? How would that process look like step to step? And why is there not to Eric, back to your point, you figure somebody would say, this is the national, since every EHR and EMR exports to CSV or Excel, generally I'll say at least 85% of them, that we don't have any standard national criteria to say once the data is exported, these are the steps that need to be taken to start your manipulation, not do an audit, but to get the data in a format to then be used to do something. And we just don't have it.
No. But isn't this isn't this a little bit systemic and other things? So I know, Sean, you've spoken with, and Jordan, you've met Jared Walker from $4, and I talk a lot about $4 because that's a passionate not-for-profit that we're involved with at Advise. And Jared will be the first one to tell you one of the entire premises behind $4 was the lack of consistency in being able to apply for charity care. So we could take anything in the health. I mean, you could take it with a lot of different things too, but in the credit card world, all the credit, if I buy a chocolate bar in New Orleans and I'm not supposed to be in New Orleans, I get an alert from my credit card company, right?
That's right.
And all the credit card companies do that. And, same charity care. Why is it that there's no consistency? Charity care has in part some federal regulations under disproportionate share hospitals, dish payments, and things of that sort. And so why isn't there a standard that if you are a hospital seeking to have someone apply for charity care, that there's a national standard for doing that? I mean, it is amazing to me that there isn't a national standard in our healthcare system for certain processes that exist. And there's always going to be a circumvention of a process or of a rule. I mean, that's what fraud is, right? Fraud is the intentional circumvention of of something. But it is just amazing to me how we don't have some sort of a standardization for something as straightforward as an EMR system, in which the government has created an incentive for having an EMR system and the desirability for it to have collateral uses, over, across patient care continuum.
Well, I think the fight of that, to Sean's point, we saw in the final rule, is reimbursement continues to go down and down. You're going to force this action that we've seen the writing on the wall. We've been talking about it. People have we've chosen not to do it. And now by force, we're going to have to address some of this standardization because it's the only way to offset the operational cost of the decrease in reimbursements.
Well, when your my personal doctor, I go to him for a checkup every year, and I go in the office and he brings out my patient file, which is about this thick. I've been going to the same guy for 20 years, and I have the conversation with him every year. Why are you still bringing out a pen and paper?
I had a really smart aleck comment that was going to be in line with like an Eric Rubenstein comment, and I just can't bring myself to make them.
Are you a better
I don't
person?
know why.
That's crazy.
Come
on, I'm ready for it. That's why we're here.
I mean, that's why we're doing this after hours, right?
It is coffee compliance and Chuckleheads. Chuckleheads isn't always about the bad guy. It could be about I mean, it is what it is. I take my lumps appropriately.
But no, and to Eric's point, I think there's a lot more doctors in that category, Eric, that are in that paper-based. I know people think there's no way on paper. I think you would be astronomically surprised at the number of docs.
No, I mean, my doc once said to me, the 2% that the government gives me, my Medicare 2% for interoperability by using it, he's like, it would cost me $80,000 or $100,000 to have a good system in place that did everything I needed it to do. He said, this package of paper costs me $4. I mean, and there's something to be said about that. And I just feel like, I think some providers, when they sign on to use an EMR system, they're playing like an advanced version of rock, paper, scissors. They're doing like rock, paper, scissors, Spock and Snake, right? They're doing it with 5 or 6 different things. But at the end of the day, it's a gamble. Like, is that 2%? My doc says to me, that 2% is not going to cover the cost of my system, the yearly, and then he laughs and he says, this pen was a box of these pens is $3 from Staples. This package of paper is $4. This hole punch is $2. I've got enough to do what I need to do, and I know where to find your stuff. And the other thing is, the paper never goes down, right? I never need maintenance on it. I don't have to do this to get it to, he's like, I just take another piece of paper out and it works.
That's right.
And there's something to be said about that. So if, when you're a solo provider,
That's the system design that's killed us, because that 2% then becomes exactly that. Why the heck am I investing that much money when there's nothing to? I'm going to just take it on the chin every year. I mean, you can't do that.
That's right. So Jordan, can you talk for a few minutes about some of what's going on with the OPPS and in the inpatient arena? Some of the high level stuff.
Yeah, I mean, so what we saw in the publication on November 2nd of the 1751 final rule and the 1753 final rule, which was, to Sean's point, the physician fee schedule for 1751 and the outpatient surgical for 1753, the final rule. Really, what we saw was inside the OPPS. Not near as intriguing and a much shorter document than the MPFS, but we saw one thing that we knew was going to happen. Obviously, the radiation oncology alternative payment model made up almost, I want to say it was 300 pages of that document that it went over to move that forward. Now that was a model that was argued and fought pretty hard. But to look at, again, a consolidated payment model, to Sean's point, based on data and standard deviation of practice for oncology care. Obviously, there's some things that we would consider probably not the most accurate in that model for reimbursement, but that was one of the highlights of the OPPS. I'll shift gears quickly to the MPFS and say that one of the largest updates was what we call the clinical labor pricing. And I can't stress this enough for the guys that build global, and really the people that build global, because there's global tech professional on the MPFS side. And what you saw was the professional side got a slight bump in a lot of the codes. And so a lot of people thought, man, that's great. But with the clinical labor update, that was offset by a much larger technical loss, which means your overall global, for the people that are billing global, saw a decrease. And they just reevaluated a bunch of the job codes. I mean, from nurses to dietitians to radiation therapists to medical sonographers, cardiac sonographers. They redid all that. And so it's about neutrality, budget neutrality. So if you're going to get an increase one way, believe me, something's going to offset it and take it away from the other. And so that's exactly what we saw. So I think a lot of people are trying to wrap their head a little bit around that. But on the MPFS side, I think those were the big takeaways, is what Sean had said.
And there's a couple of other things too. The agency also finalized an extension for services added to Medicare's telehealth list. Eric, one of yours and my favorite things to talk about during the COVID-19 PHE until calendar year 2023. The rule also extends inclusion of some cardiac and intensive cardiac rehabilitation codes on the telehealth list through the end of calendar year 2023. And then for those that are interested in the various vaccine administrations, the agency finalized in the rule a higher Medicare reimbursement rate for the administration of certain vaccines. So the rule now specifically states that Medicare will pay $30 per dose for the administration of the influenza, pneumococcal, and hepatitis B virus vaccines, and they will continue to pay $40 per dose for the administration of COVID-19 vaccines. The last part of that.
What's the point? Is the extra $10 because of the special handling that the Pfizer and Moderna need with regard to refrigeration versus J&J? Like, why do you get $10 more for administering something that you administer the same as any other vaccine?
I would be lying if I gave you an answer. I honestly, I don't know. But I do know that Pfizer said they can get children from almost zero to almost zero. Did y'all see that one the other day?
No.
Yeah, that in their vaccine for children, where children have the lowest infection rate and lowest mortality rates and things like that, they said they can get them from almost zero to almost zero with their vaccine. I don't know who puts this stuff out from these organizations. I mean, I'm not trying to be facetious. I mean, that's literally what their press release said.
Well,
And
then
was,
that's coming on the heels right of the vaccination for 5 to 11-year-olds.
Right.
So we have that now in the mix that we saw. But I mean, half of the OPPS final rule was price transparency. The ROAPM basically made half. The price transparency was just super clear. They're not backing away. And I just think overall we're going to have to look at things a little, look at the data and try to be a little smarter. There's also going to be some accountability factors to all the vendors. To y'all's point, and what we were talking about is we're spending tons and tons of money for a system, yet we need another system. It's almost like being at the pharmacy, right? You never cure the disease, you just treat the symptom. So we need this software to do what this one won't, but now we need this one. It's like, I think we're going to see in this value-based care environment is some people really, vendors and products and solutions getting exploited was, do they really add value? Because now cost becomes an even larger scrutinized point.
Well, listen to the costs here. Medicare reimbursement rates for in-home administration is $35.50 through the end of the COVID-19 PHE, and $450 for the administration of COVID-19 monoclonal antibody treatments in healthcare settings. And the rate for doing in-home administration of monoclonal antibodies is $750. So there's the question. Why is the rate of reimbursement higher doing it in the home setting versus doing it in a healthcare facility? I don't know.
And what's interesting is that if you compare E&M reimbursement for a home visit versus an office visit, the E&M for a home visit was traditionally less than the parallel E&M for an office visit, because the argument was, I think traditionally the argument was, your overhead costs are less. You're not paying for your RVU is less. You're not paying for the overhead and all of that stuff. So,
yeah, you're not paying for the equipment, the facility,
right. So I mean, I don't know enough about getting the monoclonal antibody, but is there certain handling, refrigeration? Is there something special? Obviously, there's the manner in which a monoclonal antibody is going to be administered is going to be the same whether it's done in my living room or if it's done in the emergency room or whatever. So, and then you've got, so from the other piece of it, the definition of a clinic. So in Florida, where I'm sitting right now, they have monoclonal antibody centers. The one in Orlando is in the parking lot of a stadium here in Orlando. And you get your positive COVID test, you go over and you get your monoclonal antibodies at like it's a state run center where the state pays for it. So is that a clinic in that definition? Is it like, now the government's not reimbursing for that. The state is covering that cost. Like you don't need to go and show your insurance.
Yeah, what's the side of service exactly? And we're going to see a lot of side of services move away from the hospital. I know your inpatient only list, Sean, that you talk about the surgery. We were going to do everything at the ASC, then it comes back to the hospital. That's a losing battle. Things are going to get moved. That's going to get fought. Things are going to have to move to more cost-effective centers when there's no variation in quality.
Yeah. Well, that's really interesting because, we have been now engaged on 2 new cases. Jordan, you're part of this. These are 7-figure cases with a commercial payer who is now looking to recoup monies for services rendered during the COVID-19 pandemic. Tied to Eric, your point, they're saying these people walked up, they got swabbed, and then they went over and had whatever it was done. And these are not considered to be clinics, and they're trying to recoup all of this money now. So, folks, I think the message that I have, and Eric, you, Jordan, hopefully you'll agree. If not, you guys will always tell me if you don't. you better go back and verify the place of service that you've used. You better go back and verify the documentation in the medical record. You better go back and verify your primary diagnoses, your secondary diagnoses, your principal diagnoses, your tertiary diagnoses, and you better make certain that you dotted your I's and crossed your T's, because I'm telling you something,
it's coming. It's here.
It's coming. These insurance companies, not just the federal payers, not just the state programs, these commercial payers lost their behinds during this public health emergency, and they are going after the money.
Yeah, no, it's true. You know, I'm working on a project now with a lab that it's a traditional lab that got into the COVID testing, and they're doing the PCR and the rapid testing, and they want to do things the right way. And so they engaged us to help them with making sure that all their documentation is up to snuff for when they are audited. And so the question really became, what do we need when we're submitting a claim for HRSA? What do we need when we're submitting a claim to commercial for the rapid test? And you can get almost no answer from anyone, because the rapid test, there's no documentation. You go in, you get the rapid test, and it's like a pregnancy test. Once you get the results, after a while, the check mark that tells you you're positive or negative goes away. So what is the documentation that exists, and how do you audit something like a rapid test? Now, typically, if you get a rapid, you get a PCR as well. So those two go hand in hand. But I think that's going to be the big question is going to be with testing is going to be, what documentation can you cull together to demonstrate that you are actually rendering this service? I think that in doing all of the things that was done during the PHE, in an effort to keep everybody healthy and safe and active, and keep the country in an operational tempo, the problem will always be now that we're going back. And I think I mentioned this today in a post on LinkedIn, the PRAC, the Pandemic Response Accountability Committee, which is a consortium of IGs that got together, that they got $50 million for enforcement. It's just the amount of money that's out there is just it's just unbelievable. Not just the billions that the government gave, but just think about the hundreds of millions of dollars that commercial payers paid for things. The add-on COVID tests, people that went in the hospital and died with COVID, not from COVID. But
That's
yet,
right.
there was that 20% bump. I mean, those audits are just going to be, they're going to be, it's going to be a long time. We're going to be here. And I said in my LinkedIn post, the special IG for trouble asset relief, which was created after the 2008 financial problems that we had, still exists. It was 2008. It still exists.
Yeah. Spot on. And I'll tell you what, man, brace yourselves for 2022. That's all I'm telling you.
You ain't kidding, man. I mean, this is it's you hate to say it's a runaway train, but it's a runaway train, and they've overextended. They were already in a bad situation, and it's going to be tough. It's going to be tough for patients, tough for providers. You mentioned P's and Q's, having to be on your P's and Q's.
Yep.
I mean, you're definitely going to have to be on your P's and Q's, but I think we're just going to see some. And I don't know, you open a can of worms when you go down this road, but the only way the facilities may make it is for the government to write checks.
Yep. I will tell you, I don't know about you guys, but this year I've had 48 cases. 48 cases at the federal or state level. I'm not including administrative law judge hearings. I'm not including the peer-to-peer reviews. I'm talking cases that have landed on my desk from various law firms across the United States. This year, I mean, a normal year for me is like, 20 to 25 cases. 48 cases this year. That's unbelievable. And you guys are dealing with some of the excess and overflow that I'm having to deal with now, right? With getting involved with some of the the OIG specific stuff, Eric, right? Because that's your wheelhouse. That's your, that's your playground. Jordan, you and your team, which is incredible, getting involved in a lot of the data and helping us to scrub it and clean it and make sure that what we're getting and what we're producing is accurate. And the emphasis on being the best is what we focus on. This is a skill that we've perfected, that we've honed over, for me, 26, 27 years now. Eric, decades. For you, Jordan, decades. This is why people come to us. This is why people rely on us, because they know they're going to get honest, straightforward answers. They're going to get the facts, and we're going to substantiate what we provide with cited, sourced, and double-checked information. And that's what it's going to take in 2022, with the number of audits and the number of investigations that I anticipate coming down that pike.
Yeah, I think that's true.
You're spot on. I mean, this is where you're going to want to partner with somebody that knows, not just because they've had 40 years of experience. This stuff's changing quarterly. This stuff's changing monthly. And you got to have people that are plugged in and know what's going on. So this isn't just, hey, this is the way I've done it for 35 years, 20 years. I mean, the way I'm doing things today, definitely, and the rules aren't what they were 5 years ago.
No, just a couple of years ago for me, the way that I approached the case, the way that I looked at things, it's an evolution. And you're right. It doesn't matter that I've been doing this for 26 or 27 years. What matters is that I have what I consider to be my reliable sources and what I consider to be my trusted sources. And that's where I go to ensure that I'm on the right track and that I'm looking at things the way that they should be looked at. So, look, we could talk about this stuff for hours and hours and hours. I know Eric's got a hot date tonight that he's got to pretty himself up for. I will say this, and I said it on LinkedIn, and I'll say it here again.
Oh, here we go.
You look marvelous. I love that button-down shirt with the blazer, man. You look so distinguished.
Fine. Good.
I know, it's amazing. I said to the photographer, I said, "Can you just go with me all the time? Can you just?"
I was going to say, as soon as he took the picture, I saw an extra credential pop up in your name.
I wanted one like this, Eric.
Oh, like a high school prom picture, just with a rose between my teeth.
That's right.
All right. And on that note, folks, we're going to end this episode. And just so you know, we are now in season 2, episode 1 of Coffee, Compliance, and Chuckleheads. We are so grateful that y'all joined in, tuned in, logged on, and hung out with us for this hour-long episode today. Again, on behalf of myself, my 2 very distinguished, good-looking gentlemen, one with a push broom and the other one who just gets more and more dapper every time he puts on that dress outfit with his Snoopy cup. Thank you so much for tuning in, logging on, and hanging out with us. Until next time, take care of yourself, but more importantly, be good to each other.